Dr. Rees and Dr. Goldberg, thank you once again for being here with us. I'm kind of very excited because we're talking about something very novel here. And we are talking about deliberately infecting people with a virus and then treating them to save their life. So my question to both of you first is, why would anyone agree to infect themselves with the virus? Dr. Rees, we'll start with you, and then Dr. Goldberg, you can jump on with your comments.
I think that the short answer is that patients who need a transplant are in a tough situation much of the time. For kidney transplant, they're often enduring chronic dialysis, which Mr. Shelat can tell us more about. Sometimes for patients who are in need of a heart or a lung or a liver transplant, they can be very sick, spending most of their time in the hospital. And so because there's such a shortage of organs, we've been thinking more and more about, what are organs that we can use that weren't used in the past. So a patient might accept an organ with a viral infection. Basically an imperfect organ, might not be your first choice organ, but a very good organ nonetheless, in order to get out of a tough spot that they're in. What happened with this study is that Dr. Goldberg and I took a look at new therapies for hepatitis C and recognized that the risks of hepatitis C had become manageable and that we ought to use these organs that had hepatitis C in them.
And I think just to add on here, anytime someone is accepting an organ for transplant, there's always risks of known infections, but also unknown infections. And all of the patients were presented with the data that although hepatitis C treatment in the exact setting that we were doing had not really been studied, that the new therapies had been studied for many years. And, with cure rates of, 98% or higher, many of these patients were willing to take that risk rather than endure years and years of dialysis, which is assuming that you'll even make it to transplant, because we talk about the average waiting time being 5 to 7 years, but based on certain criteria, older age, diabetes, half of people may not even survive to get a kidney transplant. So I think faced with those odds, it was something that many people were willing to take.
That's interesting. We can also hear from Kiran. Kiran, you're here and you've gone through this. So what were your thoughts while going forward for the study?
Sure. First of all, thank you for giving me this opportunity. I'm really glad to be here discussing this. And I completely 100% agree with both the doctors who just described me perfectly. So in the early 2016, around that time, I was in advanced kidney disease called stage 4 of ESRD. And I was in a pretty bad shape, just to summarize it. And I was on a 10-hour per night peritoneal dialysis. And I was already on the list for a little over a year. And the PD that I was doing nightly had caused some complication, and that particular week I was actually scheduling to go for a hernia surgery. So in short, I was in a pretty bad state of health, and everything that the doctor described physically, as well as part of it mental. It does affect you mentally, socially as well. So, I was suffering, and it looked like I was staring at a very dark, long tunnel. And that is when this opportunity came in the form of a wonderful call from Dr. Goldberg. So, I was. That 2016 was a life-changer year for me. And I was suffering from kidney disease for a long time, probably 25 years prior to receiving the kidney. Although the symptoms were not present back then. They were coming back with the vengeance in 2014, 15, 16, and my GFR was getting lower by the minute. So, it was definitely a game changer when Dr. Gorbel first called me and explained me about the Tinker study.
Mm-hmm. Of course, this was a difficult decision to make, but a game changer, of course. What was your family's response towards this? Were they very supportive for this?
So just to start, how the conversation with Dr. Goldberg started, he explained me about the Tinker study in general. The phone came when I was at work and completely unexpectedly, and he told me about the study and how it works, and he said that when the kidney is received from a hepatitis positive donor, you're sure to catch the infection, the virus, through the donor. And at that time, I really didn't know much about the hepatitis C at all. I mean, I knew that it was a serious disease, but those concerns were quickly faded away when doctor explained more about the new Merck medication that they will be administering as soon as the virus is detected. So, as the conversation went on, I was really thrilled of getting the prospects of getting kidney within several months rather than waiting several years. And as doctor had said, to be that sick and to still wait for 4 long years, you never know. Patients may not even make it to the surgery for healthy enough to receive a kidney. So when this first came about, I shared the news with my family. My daughter, who is a nurse, she came along with us to a couple of meetings that we had with both Drs. Reese and Dr. Goldberg. And the doctors during our meetings explained very thoroughly and in a very transparent manner as to how the study would proceed. And it looks to me like they have thought of every single possibilities, and has to what will the patient need right after the surgery, the medication, and how they will monitor it, and the fact that they will be treating me with the hepatitis C medication called Zepatier immediately after detecting the virus was comforting to me, because they were planning on going aggressive in terms of treating the disease. So my family, when I shared the news, several of them are doctors, and some of them were concerned because of the newness of the procedure. But a couple of them were very excited. They say, "Hey, brother, you should try this. This is definitely exciting." And we have definitely thought about this thing. And when I signed my consent, I was completely relaxed in my own mind, with a lot of faith that things are going to be working out just fine. I was telling, being a research engineer at one point in my career, I knew that when somebody comes up with a trial procedure, definitely a lot of planning, a lot of diligent thinking goes into coming up with a plan as large and as novel as this one. So definitely I was comforted by knowing the details of the plan. And my wife and my daughter and my extended family, as well as all the friends, co-workers, they were all very, very supportive. It was like a rock solid.
Oh, that's awesome to know, Kiran. Thank you so much for sharing that. Dr. Goldberg, so Kiran was saying that he received your call while in office. So did you and Dr. Rees actually call up every patient you enrolled for this study?
Yes. So when we initially designed the trial, we had a lot of internal discussions about how to do this to educate the patients properly. And we decided that we first would call them to give them a brief introduction, then have them come in separately for an educational session, and then if they were interested, do consent. And, after we called a couple people, Dr. Reese and I said we would call a few people, and then we would see if the research coordinator would then be able to help. And it became clear to us right away that it needed to be one of us because patients had a lot of questions, both in terms of the study, but also their own health and how it could affect them. So we would literally just split up the list, and if it was a given day that Dr. Reese had more time, he would make the calls. If it was me, I would make the calls, and we would cold call these people. And like I say, it was probably more awkward than a blind date call because we were calling these people saying, we're from the Penn transplant team. We want to talk to you about a study where you could get transplanted faster but get a kidney from a donor with hepatitis C. I think over time we became more comfortable with the conversation, but it was something that took some work, and we did have an IRB-approved script to ensure that we were giving all people the information in the same manner.
Yes. So, Dr. Goldberg, what was the criteria that was followed to make the selection of people who were approached?
So the way we thought about this, and obviously this is with a lot of input from Dr. Reese and the other nephrology colleagues, was we wanted to identify people who seemed to have the most to gain because there were potential risks, so there had to be benefits. So we looked at people that didn't have much time on the waiting list and thus would be expected to wait the longest for kidney transplant. We also sought out people that didn't have any underlying liver disease, and we did, beyond just the routine blood tests that were done for all people on the kidney transplant waiting list, we did extra testing and a special ultrasound to make sure that they had what we called a quote-unquote normal liver to really maximize safety for the patients. And then there were a few other exclusions, and I think the other big one is that when we spoke to people, we had to make sure that they didn't have a potential living kidney donor because we would tell them that ultimately that would be their best option. And those were sort of the main criteria that we looked at.
Interesting. Dr. Rees, there's one question that has come up from the audience as well, and I guess this is something that was even I was a bit curious about. In the U.S., apparently, the average waiting time for kidney transplantation is more than 5 years, and especially for patients with types A, B, and O blood group. And I understand from the study protocol that was online that patients with AB blood group were excluded from the study. So does blood group or type matter for kidney transplantation in general?
Yeah, it matters a lot. And basically, I think that it's hard. It becomes difficult to really give a clean answer to the question of how long will it take for you to get a kidney transplant unless you know the patient's blood type. So, just to reinforce what Dr. Goldberg was saying, we really tried to choose patients who were not likely to get a transplant without hepatitis C anytime soon, patients who were in this tough spot that they had to wait a long time. And I also just wanted to say that, and of course, patients, the implication here is that patients with AB blood group are a little bit more likely to get a transplant sooner because they're compatible with more donors, in particular living donors. And I just wanted to comment also that, listening to Dr. Shelat, or to Mr. Shelat again was, it just was great because he provided such an excellent example of, he was a very educated person, understood technical information, brought family members in and thought about it a lot. And we worked very hard on the informed consent process, and I think we should all be so lucky to have well-educated patients like him. I think one other a struggle that we faced and that was important to have the IRB's input on was just to try to make the materials as straightforward as possible. And I think whenever you're dealing with some complex consent procedures like we faced here, we learned very quickly together that when people brought in their friends and family, that was a very good sign, because I think when people undergo research like this with so many complexities, the more kind of support they have behind them, the better off they are, because there's just a lot of information to take in. And that was definitely true with Mr. Shelat. Having a daughter who is a nurse, for instance, made us feel much more confident that they'd really had a chance to understand what was being said and make the right decision for them.
Yes. Thank you, Dr. Rees, for that input. So actually, I'm trying here to, walk through this entire process of having to approach people, get them to consent for the study, do the preliminary test, make sure that the recipient is ready, make sure that the kidney is available. So I know, Dr. Goldberg, you did touch a little bit about how the kidneys are, what are the exclusion criteria and what are some of the inclusion criteria that you use for selecting the patients and the organ that we're going to be transplanting. So how do you select these for transplant? Like, I know you did mention, did you any tissue mapping or any other procedures performed, and how are they just matched with the recipient? Just a quick layman, so that the people listen can understand how this actually happens.
Right. So there are several things that go into compatibility of the donor and the recipient, and it's more than just the blood type, but there is tissue typing that goes along at the time any kidney is offered, and that involves both what's entered into the electronic donor matching system, but also blood samples are sent of donor blood to the recipient hospital for matching. That is done in any kidney transplant. Now, the one unique part of our study is that the drug that we were using from Merck, that was donated from Merck, Zepatier, only works against type 1 and type 4 hepatitis C. So as a result, we had to institute, with immense help from our molecular pathology lab, a system where at the same time tests were being run to make sure the donor and the recipient were compatible, were to check the genotype or the hepatitis C subtype of the donor's blood to make sure it was a type 1 or type 4 donor, because we only use donors with those two types because Zepatier works best against them and is only FDA approved for those two groups of patients. Now, we had fairly broad criteria for kidney donors. They had to be younger donors. The kidney quality score had to be below a certain value, but there was a lot of discretion ultimately to the kidney transplant surgeon on call, because ultimately they were the ones that would be implanting the kidney and doing the procedure, and we want to make sure that they still retain their ability to make the decision about whether a kidney was usable or not.
Mm-hmm. So were there any special precautions that needed to be taken, like for transplanting an infected organ?
No, because it's just, we always talk about what we call universal precautions, but the same thing that would be done for, a recipient with hepatitis C or one without was done here. There was obviously extra checks, to make sure that this was a patient that had consented for one of these kidneys, but nothing else was done special at the time of the operation.
Mm-hmm. So when were the antivirals or the Zepatier drug started after the transplant?
So we started it. We tested people's blood on day 3, and if it was positive, it almost always the result came back that day. We started the therapy that day. There were a couple instances just due to timing that was tested on day 2 or day 4, but we wanted to test early on and to get people started, at the time or prior to discharge. But again, that was something that we sort of discussed as a group, and we decided just for practical purposes to do.
Dr. Ruiz, would you like to comment on what are the indications to start off this drug, and how long does a patient have to take this?
So basically our view was that we would treat any patient who had detectable hepatitis C in their blood. One of the things that we weren't 100% sure about was that all of the patients would become infected with hepatitis C. But we were able to detect hepatitis C in the blood of all the recipients, and as soon as we could detect it, we started to treat. What we learned from this, which really nobody knew, is that in the early days after you get infected with hepatitis C, through transplantation, the viral load levels can be very diverse, some very high, some very low. But we treated right away on day 3, and then we would continue the treatment usually for 12 weeks. There were a few cases where we had to extend it to 16 weeks just to follow recommendations from the Food and Drug Administration if there was what's called a resistance phenotype. But for most patients, it's 1 pill a day for 12 weeks. And what we found is that by measuring the virus in the blood, time after time at study visits, that the viral loads almost invariably went down very fast and were often undetectable even after a month. And I think that was great news to be able to deliver to the patients. I remember many of these phone calls, and I think they would feel really good knowing that they were responding quickly to the treatment, and that after a short period, you couldn't even detect the virus in their blood. Dr. Goldberg, being the real expert in hepatology and hepatitis C, could comment on whether or not he sees the same things in a patient who's had the infection longer. But I think what we learned in the transplant setting is that when you know the day of the infection and you treat right away, the virus responds very quickly and becomes eradicated pretty fast.
Dr. Goldberg, would you want to comment on that further?
Yeah. No, so I think the success and the cure rates that we're seeing, matched that in people with chronic hepatitis C. The one thing that's different is that we noted that many of our patients, because we were testing and treating them 3 days after infection, their viral levels that they started were much lower than someone normally. So if I see someone in my clinic who's had hepatitis C for years, usually they have a viral load, 1, 2, 3, 4 million. But most of our people, not all of them, but most of the patients, when we started their drug, they had levels of 3,000, 10,000, so orders of magnitude lower. So they were getting to a level of 0 much faster. And we still continued the treatment for the recommended duration just to make sure that we'd optimize their chances of cure. But we did note that they went to 0 much faster than we normally see.
It's interesting, Dr. Goldberg. Was there anybody who did not get the infection at all in the trial?
No. So there were a couple. There were a couple people whose levels were 0 on day 3, and then when we checked it a couple days later, they were positive. But every transplant we did, the recipient developed hepatitis C.
Can you talk a little bit of whether this new drug, that is Zepatier, has any side effects that the patient should be aware of?
No, so all of the hepatitis C medications, that have come out over the last several years have really minimal to no side effects. And if you look at trials when they've compared it to a placebo, to a sugar pill, the side effects are very rare. People can have nausea, headache, fatigue. We didn't note any side effects above what we'd expect, and the medications that a patient takes after transplant to prevent rejection were much more likely to cause any side effects than the hepatitis C medications.
Yeah, I'd like to hear from Kiran now. Kiran, can you tell me, can you talk a little bit about that treatment phase and when you started taking the new drug, and if you're back to normal life now?
Sure. Yes. So just to confirm what Dr. Goldberg just mentioned about side effects, I had absolutely no side effects at all, 0. And we were totally surprised because in the previous treatments with high dosage of prednisone and some other medication, I was definitely being bombarded with lots of side effects. But during this treatment with I was on dozens of various medications plus Zepatier, but fortunately there was no side effect at all, absolutely none whatsoever, to the extent that I didn't even have any surgical pain per se. I didn't even take a over-the-counter Tylenol for any kind of pain. So I really was very lucky, and especially Zepatier did not offer any side effects. And I was feeling really well within first just few days. Even while I was in the hospital, I started walking around and feeling better, and just excited to get out of the hospital and return to the normal life. And I started feeling better every day after the surgery. And if I have to talk about today, I'm feeling 100% back to where I was maybe 10, 15 years ago. So in terms of side effects, there were none whatsoever. And during the recovery time, there was some issue regarding blood pressure, but that was corrected after a few adjustments were made. And I had some potassium level problems, which I still do to a certain extent. So I'm not completely out of woods in terms of potassium, but that is a separate issue. But other than that, in terms of any side effects due to medications right after surgery and up until this point is basically none. I'm dealing with potassium. I'm on some medication for that. But watching the diet and exercise and the rest of the good stuff is keeping everything in a pretty good balance.
I'm so happy for you, Kiran. Yes?
So just want to bring up one point, because I know we've used the term. I mean, I've talked, and Kiran and Peter, we mentioned the drug Zepatier, sort of the trade name. And the reason why we have done that, so one of the things that was sort of important to get this study off the ground was we both ethically in our own internal safety board felt that we could only do the study if we could guarantee that we could treat the patient's hepatitis C after transplant. And because insurance is not 100% guarantee, we had to go to pharmaceutical companies applying for grants to help cover the infrastructure costs, but also to ask for donated drug. Merck was one of the companies that we went to that had agreed to sponsor it. Neither myself nor Dr. Reese were paid by Merck, but they were willing to help costs to the university for infrastructure, but also to donate the drug. So it's not like this is the only drug that can be used in this setting, but that's why, for the audience, why we're using that drug's name is that's what we use, because that's who we partnered with and who donated the drug for all of the patients.
Yeah, thank you, Dr. Goldbach, for that information. I'm just wondering, like when I was hearing Kiran, it's so good to hear you say that you're back to normal life, and I'm so very happy for you. This is like a great thing. I can totally understand what you went through and how you're feeling now. So, Dr. Goldbach, how much do we know of the effect of treating HCV post-transplantation, and then on effect on graft survival? And what is the data what does the data say for now?
Right. So I think there's a lot we know, but there's still a lot we don't know. Before this study, we knew that hepatitis C could be treated before transplant or after transplant with the same cure rates. And that's, though, in the setting of people having chronic hepatitis C. Based on what we've seen so far and other published studies or things that have been presented in meetings, it seems that even in the setting of acute hepatitis C, when you're acutely infecting people, the cure rates are no different. I think the jury is still out on how does this affect graft function. Historical data, and Dr. Reese can speak better to this, has suggested that kidneys from donors with hepatitis C weren't quote unquote as good as from those for people without hepatitis C. However, those organs were largely used in people who already had hepatitis C and liver disease, so it was very difficult to parse out, did the organs not do as well because there was something with the organs, or did the organs not do as well in terms of who they were used in? The data that we published, I think it came out officially in September in the Annals of Internal Medicine, though, showed that at least at a year, in the subset of our patients who had reached a year, their graft function, sort of how well their kidneys were functioning, was better than we would have expected based on their kidney quality score. But I think, though, that's only a year, and I do think this is why this is still an evolving field and one that is still, I would argue, still sort of has a lot of unanswered questions and is still in the realm of experimental, because we can't tell patients at this point, 5 years down the road, we think your kidney is going to work just as well as if the donor was hepatitis C negative. We're very hopeful, and the early signals that will be the case, but it's far too early to be able to conclusively say that.
I totally am. So I have just one more question before I bring Connie on. I know she has quite a few questions for both of you. I believe that this treatment is being tried out for other organs as well, and there's there's a trial on heart transplants going on as well. Can you talk a little bit on that?
Dr. Reese, why don't you?
Sure. The question is, what's our experience been with heart transplantation?
Yes, right.
Okay. Well, I think the results of the THINKER trial and the experiences of the patients encouraged us to try out a similar model in heart transplantation. So far the results were pretty gratifying. So we have conducted and continue to conduct a trial in heart transplant where we take hepatitis C infected hearts and put them into uninfected recipients. I can say qualitatively our experiences in talking to patients have been really different because many of the heart transplant patients are just, even across the room, much sicker than the kidney transplant candidates were. Many times they're continuously receiving drips of fluids to try to give their hearts a little bit of an extra push. They're often, very fatigued and short of breath walking across the room. Some of them we've talked to while they were in the hospital because that's where they were spending most of their time. So I feel the informed consent process was sometimes, even more intense. But I think the need is every bit as great. And so we partnered with some great people in the Division of Cardiovascular Surgery and Cardiac Medicine, including Rondell and McLean and Mike Acker, among others. And, they were great partners, and all the patients who've been in that trial who were able to, finish the treatment have also been cured. The other thing that's been, very gratifying for us at Penn is that, many other centers have kind of asked us for our materials and, asked how they could develop similar programs. And so we now are aware, every week of programs elsewhere who've taken up similar programs. For instance, at Vanderbilt, they've also done a trial where they transplanted 9 patients where the donors also had hepatitis C and the recipients didn't. So I think slowly the story is starting to grow, and it's happening at other places in heart transplants besides Penn.